Hello, this is Dr. Eric Klawiter, and it is my pleasure today to spend the hour discussing issues as they relate to pregnancy and pregnancy outcomes in neuromyelitis optica spectrum disorder. So just a couple little bits of introduction. So as I mentioned, my name is Dr. Eric Klawiter. I am an associate professor of neurology at Harvard Medical School, and I am a neurologist that at the Massachusetts General Hospital in Boston, Massachusetts. And I did my training in neurology and neuroimmunology at Washington University in St. Louis. Following that, I moved to Boston and have been working at MGH since 2010. I first got interested in neuromyelitis optica during my fellowship in St. Louis, and really even I guess before that as a resident, when I this was a period of time where there was really, I would say, new interest in neuromyelitis optica because of some of the advances related to diagnostics at that time. So, as someone that was that had an interest in just in general demyelinating diseases, such as multiple sclerosis, neuromyelitis optica was a disease that I would say was akin to MS and typically fit into the same group of diseases. And it really was, though, through encountering patients that really motivated my interest in general in neuromyelitis optica. And certainly that has continued as practice has grown at Mass General. The and Sorry, I'm just dealing with something real quick related to another issue that's come up. I'll get right back to the talk in a second. So, as a result of that interest, I've continued to do research in that area during my time at Mass General Hospital. Today, I'm going to focus on one specific project as it relates to pregnancy in neuromyelitis optica. Today I'll be spending some time just related to format, discussing the topic of pregnancy and pregnancy outcomes in the setting of neuromyelitis optica spectrum disorder, and then there will be some time for question and answers. So feel free to put comments in the chat function, and we'll be able to cover that at the conclusion of the more formal, although I should say informal, talk that I have planned. In just a couple housekeeping items. As I mentioned, it's my pleasure to give this talk on behalf of the Samira Foundation. And this is a talk in a series related to NMO from the experts. And this programming has made possible thanks to a patient education grant from Vielo Bio. So, in related to this particular topic, as I mentioned, my interest in this area is really motivated by my patients, and so as a fellow, there was a patient that I treated in the hospital who was 21 years old. She had so she was she had just delivered a healthy baby, and within weeks of that period of time, she developed difficulties walking. Shortly after her delivery. And then a month after that, she developed bilateral optic neuritis, and to a severe extent. Fortunately, as I mentioned, this was more than 10 years ago, but around the time that we had developed the diagnostic antibody test for NMO. And we quickly recognized that this was an atypical presentation and tested the NMO antibody, which came back as positive. So we aggressively, with that information, she received steroids and plasma exchange to promote recovery of her vision, and then was started at that time just quickly on Rituximab. But as I treated this patient, it became apparent to me as I was looking into issues as they related to her care, whether that there was very little information on what to do in this particular situation. And in fact, there were lots of questions that related to neuromyelitis optica and pregnancy, and just because it was a more rare disease, and there had not been a lot of research in this particular area, it was a situation where I think I recognized there was an opportunity to learn more about this particular area, which actually led me to doing a study that I'll talk about in just a little bit. But some of the questions that really emerged based upon not having a lot of information and guidance at my disposal at the time were things like, how does pregnancy affect the disease course in NMO? Another question is, so how should we treat in someone that is diagnosed with NMO? How should we alter treatment during that period of pregnancy and in the postpartum period in order to ensure and promote safety for the developing baby, but also how to promote health for the woman with NMO. And then there were other questions that came up, like what's the incidence of infertility in NMOSD? What are the risks for various pregnancies? And so this really started a retrospective study looking specifically to answer these questions. And so we had some information just related to multiple sclerosis, and in many cases we sort of relate what we see in NMOSD to MS, just because we've tried to grapple with these same questions in MS a lot of times years prior. And so there were some really fundamental studies in MS that suggested that relapse rate, and because both are a relapsing disease, I think there are some similarities, but there's also some differences. And with NMO, or I should say with MS, what we typically see is that on average, the relapse rate can go down during pregnancy, particularly in that third trimester. But then we see a rebound increase in actually in the first trimester or the first 3 months postpartum, and that is likely related to some hormonal shifts. So we recognize that period in the postpartum period is an increased risk. So at the time, we really didn't know the difference in NMOSD. The other thing is that there's some data that suggests that maybe in some ways there could be a favorable effect of childbirth in multiple sclerosis. But does the same hold true for NMO? As I mentioned, there are some differences just related to the immunology of the two conditions. So we conceivably could see that the different diseases behave or react differently in the setting of pregnancy. So we embarked upon this study. There were and really I think this was a great example of the need for multiple sites collaborating together to try to answer this question. And so this was an international study. There were 8 sites that helped to recruit patients. And essentially what we did was a survey related to our female patients with NMOSD. And so in total, we recruited 217 participants, of which 45 had never been pregnant, but 172 had a prior history of pregnancy. And in fact, 31 of those patients had the diagnosis prior to their pregnancy. So those were perhaps the most informative participants, just related to the questions that we were asking. Of which, of those 31 participants, 34 had live birth pregnancies, and there were 12 pregnancies that either resulted in a spontaneous or a therapeutic miscarriage. And then we also had, as I mentioned, then another group of patients, 141 participants, that had pregnancies, but that was prior to their diagnosis with NMOSD. But of interest, as I'll talk about, there ended up being a high percentage of people in the study that actually during that time of pregnancy or in the postpartum period was when they first presented with NMO. Very similar to this patient of mine that I first described earlier in the talk. So we took a look at relapse rate during various points in time. So prior to the pregnancy, during the various trimesters of pregnancy, and in the postpartum period. And what we found in this study was that, as opposed to MS, where we saw a drop in relapse rate, there may have been even just a slight uptick in relapse rate during pregnancy. But it really was in that first trimester of the postpartum period where, or the first 3 months in the postpartum period, where we saw an increased risk of relapse. So I think that piece of information it was really informative as we try to counsel our patients with NMOSD. And this was also supported by several other studies from various patient populations from around the world, suggesting, all really pointing to that postpartum period as being the highest risk period for relapse. In addition to that, as I mentioned, we discovered that actually this postpartum period was a high likelihood of when someone may have their first presentation for NMOSD. And so in this case, we found that about 10% of people in the study that had a diagnosis before the age of 40, So that's important to keep in mind. So if you were diagnosed before the age of 40, about 10% of our female participants presented in that first 3-month postpartum period. And so this was about 3 times higher than what you would have expected for any period of time prior to that. The other thing that we looked at in the study was the effect of breastfeeding, and essentially what we found was that in the 27 pregnancies where there was breastfeeding, so the 27 out of the 34 pregnancies that resulted in a live birth, or about 80%, the participants breastfed, at least for some period of time, on average for about 6 months. And the breastfeeding was considered exclusive, meaning that there was no supplement in about 75% of those cases. And what we found was that breastfeeding was not observed to be associated with risk of relapse, meaning that if you breastfed for a period of time, we didn't see that you were more likely to have a relapse. One of the other, I think, interesting things that we looked at was, so if you were participating in the study and you'd never been pregnant, we asked the reason, what did your diagnosis affect that decision? And indeed, we found that that 9 out of 31 participants who had never been pregnant cited concerns over the potential for disability as a reason for not being pregnant, which I think was notable, and it also suggests just how important it is for us to gain knowledge in this area so that we can best inform and counsel our patients. So those were a couple of the primary findings from that particular study. So I think that this brings up I think important details related to, so what does this mean for your or for someone with NMOSD who's interested in becoming pregnant? How do we apply or translate those results in order to give the best potential counsel to our patients? And I probably should have given this as a disclosure right from the very beginning, but as a neurologist, I try to do my best to give good advice in this area. But at the same time, I am a neurologist without training in OB other than during medical school. So you should consider the source for any recommendations that I make. And I would say, just as an aside, it's actually fun to study an area such as this that's maybe just a little bit outside of what I'm used to really getting involved with from a research perspective. And so I can relate back to some of the, I would say, highlights of my training as a medical student were the times where I delivered that first baby on my OB rotation. And I guess the nice thing about doing a research study in this area is that it doesn't require me to wake up in the middle of the night to drive into the hospital for the deliveries. But I still get to sort of that inner medical student that enjoyed the thrills of delivering a baby come out through working in this area. So I think what are the issues then as they relate to counseling women who are seeking pregnancy? I think that's one of the big areas, and I'll relate this back to a review paper that was published about a year ago by a number of people, physicians that are experts in the area of NMOSD, but with a specific interest in issues as they relate to pregnancy. And so we can break some of these recommendations down based upon what are issues that come up before pregnancy, what are issues that occur during pregnancy and delivery, and then what are issues or things to discuss about that are in, that relate to that postpartum period. So one of the questions that I know comes up is what's the best timing to think about starting a family, and relating back to my own experience, obviously there are a lot of variables that go into that decision. But if you've been diagnosed with a neurologic disease, I think that's another very important variable that enters into that discussion. And so one of the things that I would say is the important thing is to really use past history and control of the NMO as a guide as to timing, and also that relates to discussions related to treatment during this important period of time. So I think in general, the optimal time for pregnancy is during a period of time when you've had good control related to relapses. So, and that's variable. What does that mean? Does that mean that you have not had a relapse in 6 months or a year or 2 years? I think that's a particular question that's important to relate based upon individual discussions with your neurologist and with your OB specialist. So, but I think in general, planning around pregnancy and doing that during a period of quiescence for the NMO, I think ends up being leading to the most success in this area. And so, some of the issues that come up then, or things to consider, is that, given the potential severity of relapses in NMOSD, we really should consider pregnancy as in the time after pregnancy as high risk. And so it's important to be really careful about those decisions. Along those lines, I would definitely encourage an interdisciplinary sort of planning and discussion. So your team is made up of your OB doctor, obviously your neurologist, probably also your primary care doctor has a big role in your care. And I think making decisions together with your team of doctors and opening up communication routes between each of them is really important as it relates to this. Then, I think that the other big issue comes to what to do about the treatment that you're on. And so if you happen to be on treatment, and let's say that you're in a period of good control, you're responding to that treatment, the question is, and I think this is an individual discussion with your neurologist, is what to do in that situation. Should you stop the treatment prior to pregnancy, or prior to trying to get pregnant? Should you continue it during pregnancy? And I think this is a really nuanced question, right? And a lot of it depends upon your prior clinical course. So potentially, if you've had a period of multiple relapses prior to starting your treatment, or that those relapses have been more severe or led to more disability, I think that might push the balance towards considering how do we effectively continue treatment during this period of pregnancy. And maybe that means looking at the risk of each of the treatments as they have related to development of the fetus, and considering even switching treatment at a period of time to a therapy that might not have been your first choice, but becomes a better first choice sort of in the setting of pregnancy. So that's, I think, an important consideration, and just related to various treatments. One of the ones that comes up is Rituximab. So what to do during Rituximab use, and we also use similar treatments in multiple sclerosis, and it's a very different situation than with MS, where a lot of times we'll say, okay, we're going to stop treatment. We're really going to minimize potential exposure to the developing fetus of the medication that you're taking, and we're going to time pregnancy in such a way that we know the medication's completely out of your system. So potentially a different conversation, or a different set of considerations in NMOSD, where relapses do tend to be more severe on average, and may not have the same degree of full recovery as in multiple sclerosis. So in comparison to MS, more likely to continue with treatment during that period of time. As just an example of Rituximab, there are at least some neurologists that would advocate, treating just before you start with a dose of Rituximab just before you start to try to get pregnant. And then if it takes more than 6 months to get pregnant, retreating with another dose, if you're not pregnant at that 6-month time point. And that's also knowing that that various medications have different effects as they relate to crossing the placenta. So as it turns out, a medicine like Rituximab doesn't cross the placenta in the first trimester. So that gives you just a little added window of time in that first period of pregnancy where you're not giving exposure to the baby in that setting. And then the other important things just in pre-pregnancy, or just making sure that you're on a prenatal vitamin, you're getting adequate folic acid during that period of time. So during pregnancy and delivery, there's other considerations that come up related to this. So one of the questions that ultimately comes up is, what happens if you have a relapse during pregnancy? What to do in that circumstance? And the general thought is that in the case of a relapse, so there are certain non-fluorinated corticosteroid treatments that can be used, and you can even consider using treatments like IVIG in plasma exchange, although I think those are careful considerations using and really kind of depending on what stage of pregnancy that you're in. There's some considerations related to fluid balances during pregnancy that relate to these treatments. In the various studies, we really have not seen that vaginal delivery versus C-section is related to the risk of relapse. So my general recommendation is to make that decision with your OB, much in the same way that you would if you did not have a diagnosis of NMOSD. And then the general recommendation is that delivery would happen in a hospital setting. A lot of times it would be good for the delivery to happen in some type of tertiary care center where you really have the best expertise in OB and in pediatrics. So then the other area is the postpartum period. So there, one of the things relates to the newborn. So I think obviously we want to monitor the newborn. Let's say that that there was exposure to a medicine like Rituximab during pregnancy. We can see that that for a short period of time there can be an effect on B cell levels in the newborn. In the cases that have been examined, we have not seen that this relates to a significant increased risk of infection, which is what you would be concerned about, and that does resolve, that the depleted B cells do resolve then within a period of months. The other considerations in the postpartum period is whether to breastfeed or not, and so that also I think is an important discussion, and just relating to what are the benefits and potential risks of breastfeeding, and I think there are benefits to both the mother and a newborn to breastfeed. We just have to counter that with what are the risks, if there was a relapse during that period of time. So certainly for some of my patients, I'm a strong advocate for restarting treatment if you have not been on treatment during pregnancy, in order to prevent that relapse, knowing from our data that I presented earlier that the postpartum period really can be the highest risk period for a relapse. And so one of the things that I will typically counsel is that in some circumstances the way to be the best mother to your newborn is just really promoting your health during that period of time. And so that I think that's an important thing to consider with this important decision of whether to breastfeed or not. And then the question is, and obviously that also relates to then restarting treatment. The goal would be to restart a treatment that has a relatively quick onset of action, right? So that shortly after you start the treatment, that gives you some coverage and can reduce the likelihood of any potential relapse during that postpartum period of time. So that I think those are really a few of the important issues as they relate to counseling. Now, I think one of the advantages of the treatment era that we're in right now with NMOSD is that we have new therapies. We also have therapies that are that have been used over the last 10 or 15 years for NMOSD. We also have, with a lot of these treatments, we have the benefit of having those treatments being studied in pregnancy in other conditions. And so while NMOSD is rare and the event of pregnancy happens, but even as we can see in this study, it does tend to be then also rare or less common, I should say, to have pregnancies following your diagnosis of NMOSD. So because it's a less common event, I think one of the nice things is that we can, at least with some of these treatments, rely on some of our experience with other pregnancies in the setting of other diseases, such as rheumatoid arthritis or other conditions. So I'm not I don't know that I have really the time today to go through each of the various treatments and discuss them as they relate to pregnancy. but that's really, I would say, a discussion that I would reserve for your one-on-one counseling with the neurologist. So I'll just say that it's just really important to talk about these particular issues early on. A lot of times it's important to talk about them, these issues even from the onset of starting the medication. If you know that that at some point in the future you would be considering starting a family. So I think that in general is some of the big topics that I wanted to discuss today. Maybe I'll just spend a few more minutes just talking a little bit about what we know about pregnancy outcomes, because I didn't really discuss that too much, and then we can then we'll be sure to take some questions. So so one of the things that we talked about was earlier was what's the risk of infertility in NMOSD. At least in the study that we did, this retrospective study that we looked at. So in that case, 15% of our participants met criteria for infertility. And we also compared that to what we saw in multiple sclerosis, compared to people in the same position in MS. People with NMO were not found to be more likely to seek out infertility treatment compared to MS. And then in the case of those that did have some sort of infertility treatment, what we found was that there was success in 4 out of the 10 participants that participated in the study. So there has been various studies looking at miscarriage rate in NMO. Those studies have varied to some extent. I think it really can be difficult to control some of the variables related to miscarriage. And at least in our study, 43% or 6 out of the 14 participants had pregnancies that ended in miscarriage that happened after NMOSD onset, compared to 7% before. Usually those were first trimester pregnancies, which also tend to be the most common time for pregnancies. That was not in ours. What I mentioned, 43% was not in our study. It was in a separate study. In our study, that was actually a fair amount lower than that. It was 21%, which would be closer to what we would expect just in the general population, where it is typically estimated to be around 10 to 15%. Other complications that in our study, our study and others have suggested perhaps the risk of preeclampsia may be higher during pregnancy, so that's something to keep in mind, and perhaps relates to maybe more closely monitoring blood pressure during pregnancy. So with that, I will now look to see whether there are comments or questions, and feel free to put additional questions or comments in the chat. So I'm looking right now. And looks like I don't see specific questions. But I will say that maybe in follow-up to that, uh, um, I'll mention that if you do have specific questions, and this also relates to if you're watching this live stream after the fact, you have questions that come up, please relate them to the Samira Foundation, and I'll be sure to help answer those. Yeah, okay, so right here I have one question. So this is a question that's related, which was relayed. I'd like to know about vaccinations. Okay, for newborns. If there's any precautions around NMO patients and babies when they're having vaccines, because I know some of them are lost. And yeah, yep. So I think that one of the things that is important to consider is related to, are there any effects from the treatments that you're on related to your newborn? So in that setting of, for instance, of having, if there is some degree of immunosuppression that has been relayed to your child that's affecting B cell levels, it's important, I think, to then check that, to check if B cell levels are affected in the newborn, just not so much as related to the safety of vaccinations, but to make sure that the newborn has a robust immune response to those vaccinations. But related to live vaccines and treatment, we in general, in the setting of autoimmune disease, we try to avoid live vaccines, and I guess related to that, we but in a newborn baby, that ends up being not as who does not have autoimmune disease, that doesn't have the same considerations. I will say that these are great questions, and I do think that they are really best also relayed to your pediatrician, in that situation. So again, consider the source of the vaccines in the newborn, and take the word of the pediatrician over the neurologist. There is, let me take a look here. I saw another question. There's another question related to, what do you recommend in the setting of Soliris or Eculizumab? And so I think that this is an important question. This is one of the newer approved therapies for NMOSD. And because of that, we have less experience in the setting of pregnancy with this in NMOSD. And so this is a great example of where we rely on data that has been accumulated in other diseases where Eculizumab has been used. So there is at least one study that has looked at the pregnancy outcomes in 100 patients that have used Eculizumab for paroxysmal nocturnal hemoglobinuria. There are uses of this medication for other conditions like atypical hemolytic uremic syndrome, also a few other related conditions. And in those in those cases with 100 pregnancies, the treatment did not seem to have an adverse impact on pregnancy outcome in those patients. So it does suggest that that this may be a safe medication to use in the setting of pregnancy. Although I would say just related to its obviously we need to do more specific studies as they relate to this. But it may be a potential option to use during pregnancy. I think that, again, put that into the category of really scouring that experience with your treating neurologist, so that you can make the best decision as it relates to your personal history and clinical course. And let me here. I don't see other questions right now. So as I mentioned, if others come up, please relay those to the Samira Foundation, and I'd be happy to address those at any time. So I want to just take a moment before we conclude today to thank the Samira Foundation for inviting me to talk about this really important subject. Although I always prefer the setting of doing some of the patient education events in a face-to-face setting, I think there are nice advantages to doing this format as well, where we can where it's recorded and we can reach a lot of people that are interested in these topics. So again, thank you. It was a real pleasure to spend this last 45 minutes or so with all of you.